This week, we welcome Terry Ray, Senior Vice President, Data Security Go-to-Market and Field Chief Technology Officer at Imperva, to discuss why driving better healthcare patient outcomes starts with cybersecurity. In the leadership and communication section, your biggest cybersecurity risk could be inside your organization, subtracting the simplest path to effective leadership, how to be a good interviewer, and more. Business Security Weekly starts now.
This is Security Weekly, for security professionals, by security professionals. Broadcasting live from G-Unit Studios in Rhode Island, it's the show where we explore the business of security to improve the security of business. Your trusted source for actionable insights on leadership, communication, and innovation. Get ready for Business Security Weekly.
Mimecast has released its State of Ransomware Readiness Report for 2022, finding that most cybersecurity leaders experienced the same or increasing numbers of ransomware attacks over last year. Together with Mimecast, organizations can stand strong in the face of cyber attacks, human error, technical failure, and work protected. Mimecast, work protected. Visit securityweekly.com/Mimecast to learn more.
Welcome to Business Security Weekly. This is episode number 296, recorded March 6, 2023. I am your host, Matt Alderman, in this location for the last time. Yes, I finally get to my permanent house. Joining remotely are my co-hosts. First, Mr. Jason Albuquerque. Hey, Jason.
Hey, Matt. Congratulations. You get to move into the permanent home here soon, so congrats to you, my friend. I know it's been a lot of work.
A lot of work. 10 months start to finish, but we've been in Texas for almost a year. So yeah, it's been a journey, but we're almost there.
Congrats, you're almost there.
Yeah, thank you. Also joining this week, Mr. Tyler Robinson. Hey, Tyler. Oh, he's muted. Nope, I didn't hear him. Oh, we'll have to fix him. All right. As a member of the Security Weekly community, we are pleased to offer you 20% off your InfoSec World 2023 tickets. Join a community of over 2,000 security professionals and innovators at InfoSec World on September 25th through the 27th at Disney's Coronado Springs Resort. Experience world-class learning and networking through enlightening keynotes, informative panel discussions, interactive breakout sessions, hands-on workshops, and more. Register today at securityweekly.com/InfoSec World 2023 using the code ISW23-SecWeek20. This segment is sponsored by Imperva. To learn more, please visit securityweekly.com/Imperva. Terry Ray is Senior Vice President, Data Security Go-to-Market and Field Chief Technology Officer at Imperva. He was the company's first U.S.-based employee and previously served as Chief Technical Officer, Chief Product Strategist, and Vice President of Security Engineering. Terry has worked closely with customers on hundreds of application and data security projects to meet the security requirements and demands of regulators in every industry. Terry, welcome to Business Security Weekly.
Thanks for having me. Appreciate it. Excited to be here, Matt, and happy to have you in Texas, by the way.
Yeah, thank you. Yeah, it was a long journey, but glad to be here. All right, so we're going to talk healthcare and healthcare security. So before we get into some of the research that Imperva's done on some of the challenges around healthcare security, I'm curious, what makes healthcare unique compared to other industries? Because I think there is some uniqueness to healthcare that some of the other industries don't have to deal with.
Yeah, I mean, like every industry has their own nuances. You know, healthcare has this specific need to have information at their fingertips, or else they just can't do their jobs, right? Yes, there are the days where you just kind of grab your scalpel and go to business and do what you need to do, but those days are pretty much past, right? Nowadays, if you're going to do some kind of an operation, if you're going to do any sort of work within the body, you're usually dealing with some sort of navigation. You're dealing with MRI, you're dealing with x-rays. All of that has to be available before the surgery, after the surgery. And this is just talking about surgical, practices. All the other elements within the hospital are really, really demanding when it comes to information, and information has to be there, available to do what it needs to do. So that's one of the things that really sets it apart. I would say one of the other things that really distinguishes it from a lot of other industries is the fact that the information is not only highly valuable, but has staying power far more than, say, a credit card or something else, right? I was reading today on my way up here to Dallas from Houston that one of the online, credit card purchasing black sites, if you will, just dumped 2 million records to say, for free, please, we're going to advertise our site. Here's some free credit cards. Some of them don't expire until 2025. Well, we all know that many of those credit cards were canceled years ago, aren't any good, et cetera. That's not the same. You can't say that same thing for your address. Maybe yours is going to change, but your address, your phone number, your name, all of that stuff that just has that staying power, I can't just cancel it for a new one. It's going to be around for a long time. So that information is highly, highly valuable. It's highly critical to the organization. Organizations oftentimes will pay a ransom, whether it's a ransom on a file or a ransom on a DDoS or something else, prior to even doing an investigation, because they have to be made available. Their resiliency is critical in that business.
Yeah, we're going to talk about some resiliency at the end because it was an interesting term that came up during our prep call. But when I think about it's a privacy issue, I think, with healthcare too. It's not just name and address and that information. It's like, what diseases or surgeries or whatever am I having? There's a lot more personal information in a healthcare record than there is in a credit card record, for example, right? Which also has a very interesting slant for attackers and creating different threat vectors, I think, for the healthcare industry.
I've got a webinar coming up called The Perfect Storm in Healthcare and all this sort of stuff, right? And it is that perfect storm. It doesn't star George Clooney or anybody else, but it connects all of these different pieces together. You can almost point to any kind of regulation, any kind of thing, and it almost always applies to healthcare, particularly when you think about, I think we commonly think about healthcare in the U.S., but I talk with healthcare all around the world, right? And we're talking about very different regulations, but at the end of the day, the same flavor of needs and requirements come out. And you're right, it's about private data. It might be privacy for GDPR or PIPEDA or other places. It might be HIPAA and other things here, but there's always these two pieces that come to play in healthcare. There's the security best practices, the things to just keep your data up, available, and not stolen. And then the other thing, which is that foundational piece, which is compliance. And it's the marriage of those two pieces that exist in every organization, but those two really come to light, I think, very strongly in healthcare, such that, we know we need it. And that's the challenge in healthcare, I think, that you run into is it's not cheap, unfortunately. And so it's a low margin business in a lot of cases, and it's hard to get the stuff that they need to really solve a lot of their problems.
And Terry, I mean, I know this happens in a lot of industry, and it happens in healthcare too. Are we still in a place where compliance is driving the behavior when it comes to security versus security being the indicator of good compliance, right? I mean, I've always taken that stance of have a locked on security program that should drive your compliance, right? Your ability to be compliant versus the other way around. And I know healthcare has struggled over the years with, being a check in the box compliance first type, industry type vertical.
I can only answer from my experience, right? And what I see with regards to the application world, the web application world and the data world, the answer is it kind of depends, right? It's always the answer, right? It always depends, right? But in the application space, I see security as best practice. They recognize they need to protect their applications. I don't think it's because of fast healthcare interoperability resource, FHIR APIs, or any of that. In fact, when I talk to providers, usually the providers don't even know what FHIR APIs are. They just know that they use or create APIs. So I don't think there's so much compliance on the application side. They just know they need the resiliency. They need their applications to be up and available. Where I do see compliance, unfortunately, being the primary driver and not security, is back behind those applications in the data space, where you've got all this data that sits back there and hundreds, if not sometimes even thousands, depending on the size of the organization, of people that have access to that data. And not many people in the organization that can actually answer really basic questions about who touches it? When did they touch it? Are they supposed to touch it? And to me, that's the challenge. Is it's not the same answer in both places when it's the same path to the data. Your path is straight through your application, straight to the data, but only if one aspect of it is really security driven.
Yeah.
Do you think there's a place and time where we get to a point where we can remove some of the, I would say, some of the monetary value of these PHI records from like a PCI standpoint? Like we start to remove the credit card numbers and we move to a token base and we start to get to the, the contactless payments and get to where there's not a credit card number that gets exposed or breached. Do you think we can get to some of that same level of removing PHI and the data that goes along with it, and kind of tokenize some of that so that the healthcare providers aren't liable for it? We are at this point where we're going to play this cat and mouse game, and the attackers are going to continue to win unless we get to a point where that data is not worth anything, or they can't access it because of how it is.
I think we could. How long did it take for PayPal to become hot? Or, forever you saw where you could, pay with your iPhone at this sandwich shop or that sandwich shop. And now it's ubiquitous. It's everywhere, right? You can pay with it, and you can maybe, I don't know if it's thinking COVID or whatever. You just don't use money anymore that much. Maybe healthcare becomes that same way. I'll admit I will try to use a payment processor or payment, tool, a PayPal or what have you, before I'll try and use something else. Yes, they could have their own problem, but if it's one place that stores it and I don't have to give it elsewhere, some sort of a healthcare broker sort of thing could be certainly a helpful place, right? If you brought enough people on and there was a catalyst that encouraged these organizations to move away from their own ability to do business intelligence and their own seemingly need to do their own business intelligence and maybe accept it from a broker. And I think that's one of the challenges here is in every single provider you go to, it's not just about their electronic medical records or their electronic health record. It's what happens behind that and their ability to do analysis on what people are using, how using, what's the effectiveness of all of this. And you can tokenize some of it, but it'll be an interesting, I think it would be helpful. I just don't know how long it would take to get to that point of them saying, you're right, we shouldn't have this information. Other people should do it and give it to us in some other way. I'm not sure.
Well, there's two catalysts that are possible, right? The insurance industry and or the federal government through Medicare, Medicaid programs, right? I mean, would be in the healthcare space, those would be the two potential catalysts. If this were something that came down from insurance or from the federal agencies, that could get us to that state. But, I don't think they're ready to do that yet.
Yeah. I mean, we're always going to get the challenge from the researchers, right?
Fast.
Yeah. I mean, at the end of the day, the data is gold for these organizations, though, right? And they need it for the research capabilities, and they're going to, you're going to have researchers, with pitchforks and torches, not wanting to give up control of the data because that's their livelihood. That's their analysis. That's how they do business. So it'll be a struggle.
Yeah. Terry, so Imperva did some threat research in the healthcare space. Give us an idea of what's unique to the healthcare space from an attack perspective. And then we'll talk about what are some of the potential mitigations here for the healthcare industry as well.
Yeah, so we mentioned, or I mentioned earlier, the resilience piece. We talked about it in the prep for this call as well. Resilience is hypercritical, and so it's why you see in January, and this is part of the blog that we did and the research we did in January. Of course, we saw KillNet. KillNet was a DDoS, if you will, against very specific, very notable healthcare organizations. It wasn't a super sophisticated DDoS, but and I'd say it was fairly easily mitigated with the right technology. And our customers, and to be fair, even some of our competitors' customers were well mitigated. Customers, or I should say non-customers out there that had it, then of course they had some resiliency, maybe issues that were there that ultimately got rectified. I think, resiliency is one aspect to it, but the other thing that makes it unique is, I said earlier, it's that perfect storm, and it is different than, say, financial services, which is, I'd say, the next closely targeted, industry. In fact, they're more targeted, but they're also more regulated. They also have very monetizable data without the same kind of staying power in some cases in those worlds. So when I think about the healthcare space, I think about what happens here. In the healthcare space, it's one of these things where you're looking at the data and you're looking at what people are doing to the data. But at the end of the day, the provider themselves have to have the resources, both monetarily, people-wise, time-wise, and expertise-wise to do whatever they need to do, technology, consulting, what have you, to solve the problems. And that's a big, big difference than what you see in financial services. In an FSI organization, you may have a security team that has 200, 250 people on the team or more. In healthcare, we're looking at a small little handful of people. And oftentimes I see the transition, the career progression from healthcare is to leave healthcare and to go to another regulated industry like financial services once you're good at it. So it's a bit of a breeding ground, if you will, for the newer people. You've got a lot of people that, yes, they are there for a long time, but then they don't have the budget, then they don't have the time, and they don't have oftentimes even the skills of the training. So I see a lot of outsourcing happening in healthcare that you don't see in other heavily regulated businesses. Going back to, it is kind of that perfect storm of highly regulated, highly monetizable data, small teams, oftentimes a little bit less skilled because they're a small team, less budgets. All of this comes together to create challenges in the healthcare space that talk about the impacts that we talked about earlier, resiliency, loss of data, ransomware, and ultimately gaps in their security.
How big of a play these days in risk to healthcare organizations is technical debt? I know in healthcare, there was a lot of technical debt issues about, legacy equipment, legacy applications, the inability to do upgrades because of budget and resources. Does technical debt still play a big role in some of the risk?
It does, yes. Not so much as FSI, right? So FSI, where you go all the way back to, DB1 and old mainframe and AS400 and other stuff. You'll see that in some of the universities, the, medical universities and those sorts of things. But in major providers, usually they tend to be off of all of that. In fact, a lot of them are really, because of the lack of skills or the lack of budget, if you will, the small teams, a lot of them have just said, we have to move things to the cloud. We have to move to hosted environments. We don't want it in our own data center. We're happy to have somebody own this stuff for us. And even though they have small budgets, they're willing to pay more to let somebody else do it. They're trying to maintain staff to do it. And I'm not saying it's not a bad thing to do, but it is a shift. But I think the result of that shift is it does get them off of some of the legacy systems, moving them to a more hosted type environment. And I'll use the example of an EMR, and it doesn't matter which EMR, electronic medical record system that they use. Fact is those systems keep themselves up to date. They always have to have some of the newer stuff. And if you move to hosted, then of course you're on the latest and greatest anyway with the same technology you're used to. So that's what I see is I see them modernizing a little bit more rapidly, not because they want to, but because they really need to from a people's and time perspective.
No, that makes sense. And that was a little bit of a seed question in all honesty, because that migration to the cloud now exposes these organizations to misconfiguration and human error, right? Which we know is a large part of the risk that's out there today. So that was the second part of my question. Now that these organizations are migrating to the cloud, are they paying attention to their responsibility when it comes to managing that cloud infrastructure?
Yeah, posture management's always one of those challenges, right? What is your current appetite for misconfigurations out there? How well do you really trust the consultant or the hoster that you have? And what checks and balances do you have? And back to regulation, what are your regulators going to accept as best practice from your own hoster? I deal with this right now with electronic medical record systems, where for years their application tier of an EMR has been very well logged, very well secured, and all this. You don't see a lot of frankly exposures and breaches from EMR front ends. But when you start to peel that back a little bit and you look at their back end, for example, frankly, many times a provider can't tell me who has access to it, how many people have access to it, whether people are touching what records. It's just a wild west behind the back end of it. And so it's one of the things we're trying to solve now, which is you need to have eyes back there and you need to understand what that risk is. To point, I was talking with one provider the other day, and they said, look, it's great, Terry, that you can tell me who accesses my data, when they access, how they access, and all those other things that they're supposed to do. But I really need you to help me put context around that and tell me what the risk is on this particular data. Give me a score. Make the score up, but put some metrics around it and compare it to peers so that I can understand whether I'm getting better in my risk or getting worse in my risk. Because right now I just don't have a key performance indicator on whether I'm doing a good job or a bad job. And I think that's probably pretty common across that industry. And not even it's common across a lot of industries, but certainly in healthcare, where as they move to the cloud, certainly that posture, not just infrastructure posture, but even data posture, right? Managed RDS, managed Azure, and all the others. What are those configurations?
Yeah.
I think that also lends itself to establish more responsibility for many of the vendors that have shrugged off some of their, integration, some of their security malpractices, all of those things that it's very difficult for a hospital to come and tell a provider that does thousands of hospitals, like, you're doing this wrong and this is very insecure. Well, everyone else is doing it this way and we're actually the vendor, so you can either take it or leave it. Putting some of that onus back on and providing that visibility, I think, is one of the key steps to get these vendors, especially in healthcare, to take care of some of the legacy codes, some of the legacy protocols, and then put the responsibility back to them so they can see that. So the metrics on that side is phenomenal for that very reason.
If you look at, so I've always been amazed at the limited amount of information that exists, and I'll pick on databases for a second, structured data, but the limited amount of information that exists in a database log of behavior of what happened. For years, for example, at Imperva, we've been able to tell somebody, hey, Terry accessed this table and he took 1 million records. And before I really became, savvy in the database world, I didn't understand that it was actually the Imperva telling you somebody took 1 million records. The database almost never actually logs the number of records taken or the number of things changed. That's done within the communication protocol itself by some third party. It's the only way to get it. And so even talking with one of these very modern vendors of databases that sit behind EMR, talking to them and saying, hey, look, wouldn't it be great if you guys took the ownership and said, we are a healthcare database. We're going to do it right. We're going to put the number of records people access in the logs. So it's just that easy to get. And the first answer back from them was, yeah, that's easy to do. We'll do it. And then about a day or two later, they're like, no, we're not going to do that. And so it is this challenge, I think, within the vendors to say they need as much education as anyone else. But to be fair, I think some of these vendors, not just database, but any vendor that's storing data, needs to have that Medicare, federal regulation, et cetera, to come back down on them and say, there are very specific things. If you are a tool that does certain things like store data, there are certain requirements that should be inherent in your own system to make the users of your system that much more informed about what's going on in there. And it just doesn't exist. And so in that case, it is a little bit challenging when you look at the hundreds, if not multi-hundreds of vendors in structured, semi-structured, and unstructured data. And they can all choose to do whatever they want to in terms of what information they're going to provide you at whatever time they're going to provide you. So it is very difficult, I think, for a provider to ultimately be able to answer those questions, certainly on their own.
Yeah, I mean, I think the challenge is there's multiple challenges. Lots of vendors. You don't control the infrastructure. You don't control these applications. Terry, I'm a big app user data guy, right? Those are things I should try to control. Applications, access to those applications and the data in the back end. So if you provide guidance to a healthcare organization, what guidance would you give them to get their arms around the app user data side of this? Because to me, that's really where they have some level of control. What should they be doing?
Like I said, I think most of them have done a good job from the outside in to the application. Right? They've got, SSO, they've got federation, they've got some form of identity access management. They've got a lot of different tools. They've got logging in through mobile. I'm touching my phone over here. They've got, all kinds of APIs, and there are regulations around the development of healthcare APIs, at least, and it focuses a lot on authentication and identity and all of this. So they certainly know when Terry is logging in to this application, they've got a lot of things that connect Terry to me, my device, and other things. It's that back end piece where I think there's still a lot of work to be done. And again, not just in healthcare, but certainly in healthcare. Okay, so Terry connects into your app, and your app is called myhospital.whatever.com. And you get to myhospital.com, and that application connects to the database with database user 1. Doesn't mean it's Terry. It could be any one of 100,000 or 1 million different users. It's database user 1. You don't know who it is. You've lost the context of whether it was Terry. And you can argue whether you need to know whether it was Terry or not. In a lot of cases, you don't. You just need to know whether the application is doing something it doesn't normally do. And you can say, I don't want to allow that, or I do want to allow that. And you may never find out if it was Terry, or you have to go back and spend some time in logs and do it. There's technology that exists to tie all of that through. I just don't find a lot of companies really doing that. Compliance doesn't require, PCI says they require it, but it's hit or miss, depends on who your provider happens to be or your auditor happens to be. There's just not a lot of drivers for it. And to be fair, I would say you can do good security without having that tied together. What you do need to do, what my recommendation would be, is you must be able to know who is accessing your data and when they access your data. I'm not talking about Terry on the outside. I need to know if it's an app, and I need to know which app it is. I need to know if it's a direct database user, and if it is, who is it doing that? Because analytics wise, I need to be able to compare a human user accessing a table or a file or whatever else to an application accessing a file, which is going to usually do it very, very differently. And if I can start to tie these things together, then I can start to use analytics. I can start to use some level of machine learning, some clustering and peering and fun things that happen in that world that allows me to say, you know what? The app only touches that. That's the only person that ever touches that is the app. But now I see Terry touching it and not just managing it, but he's actually looking at records in there. That's not normal for Terry. I can't predict what Terry's going to do everywhere, but I can tell you that's not normal for Terry. Let me go and investigate that a little bit. And that allows me to do something with it. But it all begins with being able to track who is accessing my data, app, user, which user, etc. And that to me is the core. If you've got that, then you can start to build controls from that for as deep as you want to go.
I love it. App user data. Basically in that order. Terry, thank you so much for joining us on Business Security Weekly.
Happy to be here anytime.
To learn more about how to protect your applications and data, or to learn more about Imperva, please visit securityweekly.com/Imperva. We're going to take a quick break and then cover the leadership and communications articles for this week.